Please note today's session is being recorded. If you have any objections, you may disconnect at this time. Thank you very much. And on behalf of the National Cancer Institute, I wish to welcome everyone to today's Implementation Science webinar. We are excited to be joined by our speakers, but before we get started, a brief word about logistics. All lines are in listen-only mode. We ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded and muting all lines will help us to avoid any background noise. We encourage questions and comments. Questions can be submitted using the Q&A feature on the right-hand side of your screen. Type your question to the provided Q&A field and hit submit. Feel free to submit your questions at any time during today's call. We will be using the chat panel to share resources throughout today's talk. You may need to activate the appropriate panel using the menu options found on the bottom of your screen. Lastly, we recommend navigating to the View menu at the top of your monitor and selecting Hide Non-Video Participants, as this will give you the best glimpse at our great speakers. And with that, I'll turn it over to David. David?
Thank you, Sarah, and thanks so much to everybody for joining us. As you can see from this crowded slide, we have some wonderful opportunities to learn from some great speakers today. If you saw the title before we got going, we're focusing on the intersection between health communication and implementation science, and it's been part of NCI's webinar series over recent years to really be thinking about intersections between implementation science and other really important relevant areas of research. NCI is somewhat unique among our within our agency of having had a long history of really wonderful work in health communication research that doesn't have as many parallels at the other institutes. I know this from 13 plus years at a different institute where we didn't have such rich expertise and such a wonderful portfolio. And so when a few years ago we were thinking about implementation science in the broader context of our behavioral research work, our healthcare delivery research work, our epi work, as well as our surveillance work, we wanted to make sure that we didn't only stay at that surface level, but really started to move into learning from our wonderful experts, as you can see again here today, and really thinking about how fields that at times are artificially separated can come together to the betterment of those who are struggling with cancer across the cancer continuum. And so the goal today is really to get our speakers and you all engaged in a conversation about how we can take most advantage of all of their expertise and experience to chart a path forward, exciting research directions. We, of course, are in this incredibly evolving and challenging communications environment, and it just seems natural to be able to focus on some of these cross-cutting issues so that what we implement, which we hope to be the best possible care for all, doesn't get trapped in our inability to best understand how messages, how information, how evidence influences our key stakeholders across communities and clinical settings. And so with many of our other webinars as a model, we do want this to be a facilitated discussion. We don't have, outside of the slides that you're seeing, a lot of slides to go through, but more to really engage all of you and get a sense of what are the questions that you have for our speakers and how do we get to those. We have a couple of overarching questions that we'll start with. But of course, that's to give you a few minutes to then be able to put in what you are thinking and what you want to know. You'll see that Robin Vanderpool, our branch chief of our Health Communications and Informatics Research Branch, is going to tag team the facilitation with me. So I'll be on the front end, and then Robin will take us home. But just to start, so as you can see, we have Haley, we have Melissa, we have Andy, and we have Matt joining us today. And we wanted to start with each of them and just have them walk through as an initial question, if they can talk a little bit about how they first became interested in health communication science and implementation science, and maybe what each of them have focused on in their research. And of course, we've invited them as they reflect different perspectives within this larger area of expertise. So I think we want to start with Haley, and then we'll go to Melissa, and then Andy, and then Matt, with that broad question of tell us a little bit about your superhero origin story and a little bit about what you've been doing. So Haley, you want to kick us off?
Oh, thank you, David. I don't know about a superhero origin story, but I can, tell you where I started. So I'm a clinical psychologist by training with a, focus on cancer prevention and control. And I came to health communications research through my focus on disparities and cancer health disparities. And in thinking about interventions in that space, issues around cultural targeting and cultural tailoring of interventions was very important to me, important to the folks that I work with. And I think, Matt Kruder was a big part of my development in that area. So some early work, we examined we actually compared kind of more culturally targeted approaches versus more generic approaches to communicating around some cancer issues such as prostate cancer screening, breast cancer survivorship as well. Also, I've been very interested in the use of narrative and storytelling as part of communicating or as part of behavior change, particularly in breast cancer survivorship and surveillance. Now, in terms of implementation science, that is not an area where I have as much experience, although, in my role as Associate Center Director for Karmanos Cancer Institute, it's becoming much more a part of my experience. As many people might know, the whole role of community outreach and engagement within comprehensive cancer centers is to one of the roles is to disseminate and help to implement or support implementation of evidence-based interventions in a wide range of settings, right? Clinical settings, community-based settings, working with policymakers. So, so I've been learning more about implementation science as a part of that work, because it's critical, to understand those principles. And as part of that, community engagement and I think that how we interact with our community stakeholders is really is also a critical part of that. And I think it can be interesting, maybe part of the conversation today is thinking about how, the science of community engagement intersects with implementation science. So I'll stop there.
Awesome. Thanks so much. Melissa, you want to go next?
Sure. I'm happy to follow after Haley. Like her, I'm also a health communications researcher, but instead of focusing in the community, my focus is in acute care, specifically hospital settings. So I came to love communication, if it was, as you might think of it, from my clinical practice of being a nurse in the ICU for over 30 years. And what I noticed in my clinical practice was that the way I was talking to the physicians did not match the way they were talking to me. And there was this disconnect between the communication between us because we came from different disciplinary perspectives. So on my first sabbatical several years ago, I spent some time thinking about how we define communication. And although we usually think of communication as an exchange of information or a transfer of information from a sender to a receiver, there's another broader way of thinking about communication, and that is the development of shared understanding. So we need this kind of a definition of communication as the development of shared understanding. It's also been called by other terms as well. But the value of this is that when we think about it from different disciplinary perspectives, as well as the perspective of the patient, we all need to come to a shared understanding. And exactly how do we do that? So also, like Haley, I have less experience with the implementation science world, although I did do a conceptual paper which was published in Implementation Science several years ago now on this idea of communication theory and how it is practically invisible in implementation science. So when implementation science theories think about communication, they think of it almost exclusively as this idea of transferring information or exchange of information. But when we think about implementation science, this idea that evidence-based practice gets embedded into clinical practice, we need more than just the words. We need action. And thinking about communication then, the type of communication that gets to that action is when we think of shared understanding, because you really can't make much of a movement if you're not on the same page. By being on the same page, you can then springboard into action, and that's where the link can be then to implementation science. And I'll stop there.
Great, thanks for that. Andy, you want to join in?
Hi everyone. Thank you for having me here today. I am faculty at the Annenberg School at the University of Pennsylvania, and I lead the Health Communication and Equity Lab. And the types of health communication work that I do focuses on understanding different types of communication inequalities, whether that matters in terms of health outcomes, and what we can do about it in terms of addressing communication inequalities, so that we can improve cancer prevention and control outcomes. And I am trained as a physician and also served in the role of health promotion for a number of years before embarking on my doctoral training in health communication, and I come to implementation science from this discipline. There are a few key junctures in terms of how I got interested in this intersection between communication and implementation science as it pertains to cancer prevention and control. And one of these formative experiences was when I saw the inklings of the intersection between these two fields of research and practice a bit more formally when I was a graduate research fellow within the NCI-funded PEN Seeker, the Center of Excellence in Cancer Communication Research. The PIs were my advisors, Dr. Bob Hornick and Katrina Armstrong, and I was really able to take advantage of the trainee development as part of the Seeker and networking with other trainees and investigators across the other Seekers. And that's also how I got to meet Matt and his team at WashU, the teams at the University of Wisconsin-Madison and the University of Michigan, who have been working on technology interventions in terms of communication to promote cancer prevention, screening, survivorship, and other outcomes. And that was really the point where I saw the intersections between health communication and implementation science research. The work by Jim Deering, Bossica Rabin at the University of Colorado at the time was really new to me, coming from health promotion and communication. And that was really one of my first forays into how implementation science is being used in the space of cancer communication research. A second important experience that I can share. When I first started out as a new investigator at the Dana-Farber Cancer Institute, I was fortunate to be part of a cohort of the Cancer Research Network Fellowship group of fellows. And this fellowship encouraged all of us to conduct prep to research types of pilot studies, to develop R01 level grant proposals, working with mentors who are embedded within large healthcare delivery systems. I was the only communication scholar in the mix, but was really glad to connect with other scholars who were working on tobacco-related health disparities research, and specifically Doctors Ramsey Saloom and Lisa Cutter-Harris, who were both working on tobacco-related types of research. And all three of us later enrolled in one form of another of a mentored training in terms of implementation science research on the TIDERC, the MTDERC, and I did the TIDER program with OBSSR that was organized by the NIH. We continued working on multiple papers and projects fusing our interests in communication science, tobacco-related disparities, and implementation science. And I see that experience being really part of my getting work done in the intersection of health communication and implementation science. I also want to credit the incredible mentoring and advice and collaborations and experiences with my mentors, other senior scholars and colleagues throughout my career. Vish Viswanath, Karen Emmons at the Harvard Chan School, my former advisors and now current colleagues, Bob Hornick and Joe Capella, my mentor at UMass, Kathy Mazer, and Russ Glasgow, many other names I could list here who have really influenced my stretching of my thinking about health communication questions and integrating implementation science research questions in my work. So I'll pause here and happy to be really happy to be part of this panel today.
Thanks, and this, of course, is all about stretching all of our horizons. So Andy, thanks for that. Matt, you want to jump in?
Absolutely. Thank you, David. And thanks, Robin, for including me with this great panel today. My name's Matt Kruder. I'm trained in public health, but before I did that, I actually worked kind of at the intersection of journalism and media relations. And so throughout my public health training, I think I was always kind of viewing it from the lens of how can information and communication help to achieve public health goals. So for the last 26 years, I've been affiliated with a center at our university, the Health Communication Research Laboratory, which, like Andy's work, is really focused on addressing issues of health equity. And the focus of our center has been on really three broad outcomes. So we want to conduct research that that increases the reach of health information to disadvantaged populations, especially low income and racial and ethnic minority populations. Also to increase the effectiveness of information and communication to make it meaningful in the context of their lives. And then third, to use information and technology, not just to convey information, but also to connect people to tangible services, health and social services that they might need. So reach, effectiveness, and connections are kind of the focus of our work. And really all three of those goals, I think, are highly relevant to implementation science. And I suspect we'll talk about that during the rest of our time. So as I thought about this panel, I started by asking myself, what are some of the things that health communication scientists know and do that could be helpful in advancing implementation science goals? And I'll just toss out three broad categories. And again, perhaps we can explore these further, and I know the other panelists will have lots of additional ideas to build upon. One of the things health communication scientists know and do well, I would call communication planning broadly. And so this would include things like audience research to understand what are some key attributes of those that you're trying to engage, and also audience segmentation. So are there subgroups of people that hold sort of homogeneous views or perspectives, and you might want to reach them with a certain approach. A second broad category I would suggest I'd call communication design. And so this can range from everything like kind of sort of the basics of concisely capturing the essence of an idea to communication tactics like the ones that Haley described in her opening remarks. So targeting and tailoring and using narratives and framing messages. And then a third category I would call something like communication delivery and evaluation. So how is it that we could increase exposure, which for communication is essential? How do we increase exposure, and how do we assess not just exposure, but people's reactions and responses to that information? So for all of those health communication approaches, if you will, there is a base of evidence. There are established methods. There are often standardized measures that can be used. And so for implementation scientists who maybe aren't as familiar with health communication science, I think learning about those things could be valuable in their work. So I'll stop there. Thank you.
So thanks to you all for these great opening comments, and again, encouragement to our awesome audience. I'm taking a look at all the wonderful folks who have joined us, and I'm starting to see now a question. So keep questions coming, because we're going to, of course, shift as much as possible to what you want to know. And just to give you a chance, if you haven't had your afternoon cup of coffee, you'll see right here in front of you that there is a lovely, what looks like cup of coffee that is on an open flame, the fireside that we try not to be burned by, but we do enjoy its warmth. So Matt, I do want to actually pick off what you just said and address it to our other three panelists. You talked about some of the ways in which health communication science can influence what we think about in implementation science. And I did want to pose that same question to, maybe we go Melissa and then Andy and then Haley, just other observations of things that you bring from health communication science that you think might be better represented in some of our implementation science work going forward. And again, I'm seeing the Q&A coming, and so we'll go to that after that. But so Melissa, do you want to start off with that?
Sure, happy to. I think for me, it's about depth instead of breadth. So I want to talk a little bit about getting to that granular level, about what actually happens at the bedside, in the clinic, in the primary care area, wherever we are talking about doing implementation science. Because what we're trying to do is improve the delivery of healthcare. And healthcare is delivered by clinicians, nurses, physicians, physiotherapists, etc. And how they actually go about their job is really at the essence of implementation science. Now, for me, the disconnect is, however, that we are not necessarily including those voices when we think about interventions to improve implementation of whatever intervention it is. So we usually approach this from the view of researchers who come in with some great idea and they really want to implement some intervention, but without actually hearing the voices of those clinicians who actually must implement it. We also don't spend enough time thinking about the context. Each primary care facility, I've done research in ambulatory oncology, for example. My goodness, each ambulatory oncology setting was its own little world. And without tailoring what it was we wanted to do to the unique circumstances of each site, our intervention was not as likely to succeed. So I'll stop there, but just to give you that broad overview of how I see communication and being able to help out with implementation science more broadly.
Great. Andy?
I was really reflecting on this question and referring to the second edition of the Dissemination, Implementation, and Research in Health textbook that was published a few years back. And it's really shocking, striking to me when I looked at the index of the textbook that communication was not listed at all in that textbook. It's missing. It's a huge omission, and I think we could and should address that. Outside of this panel involving other communication science experts as well, and drawing upon the three principles that Matt had laid out a few minutes ago. So one of the key issues that my team has been focusing on is helping to address this issue of message and media effects at the granular level, sort of similar to what Melissa was pointing out. What happens internally when someone is processing that information once they're exposed to, say, an anti-tobacco message? What happens then? And this rigorous testing of message media effects and figuring out the impacts on the intended outcomes, meaning persuasion to adopt a healthy behavior or healthy practice, and avoiding unintended iatrogenic impacts such as rejection or reactance to the message. Those are really key skills and key research questions that we address within our field in health communication. And I think those types of experiences, those types of expertise and methods and strategies can go a long way in terms of helping the goals of implementation science research as well, and putting the evidence-based practice in people's hands and getting it implemented, adopted, and sustained over time. So I pause here and happy to hear from Haley next.
Sure, sorry about that. So yeah, I really kind of want to build upon a little bit of what Melissa talked about in terms of shared understanding, because I think my to me, that is kind of a really core piece in terms of the health communications work that I've done in diverse communities. And, you know, how do you develop those shared understandings? And just coming back to, you know, the kind of the types of partnerships you have with the community, again, the stakeholders who are helping you to create those messages, and the depth of those relationships, you know, I think are really key to that. So I think that's something that in my work, not just having a relationship or partnering with a group or an entity or a community advisory board for one project, but you know, what kind of relationship do we have? What kind of partnership do we have beyond that project? So that we, again, to again develop depth of relationship, you know, and I think that's when you kind of really can begin to stay on the same page. And I'm really curious about, you know, as we kind of move forward in this field, you know, how can we better understand kind of even the depth and the breadth of those relationships, and to what extent does the nature of those relationships then affect these implementation outcomes that we seek, you know, and do we get stronger effects based on kind of the depth of those relationships and kind of the depth of that shared understanding?
Great, thanks so much for that. Matt, anything else to add on that question? I know you teed us off.
Well, you know, I think what several of the comments conveyed to me, and especially, you know, what Haley just shared is, you know, we might want to, you know, dispel a key myth for some of the participants today who are new to health communication. So sometimes I think there's this idea that there is, the communication can have these universal, robust main effects. Kind of the idea of the magic message where, if you just get the right words, that somehow it works and works well for everybody. And that, that's rarely true. And so what is more complicated is to do the sort of thing that Haley's describing, which is really trying to understand, who are the audiences, what do they, know, think, believe, and then how can you, most effectively convey information to them. And that's kind of both the art and the science of health communication. I think it's what makes the field really, interesting and fun and challenging to work in. But I think making sure that people who are on the call today understand that is an important kind of base level understanding.
So thanks for that. And actually, did anyone want to add to that? Okay. So in the spirit of understanding our audience and building more bridges, I'm seeing that we have a number of wonderful questions there. And so what I'd like to do is start putting the questions out to the panel and just encourage whoever wants to jump in, and I'll see if there's any way I can sort of manage traffic as it is. But so I'm going to go to the first question, and again, great questions. Keep them coming. We'll get to as many as we possibly can through the remainder. And so there's a question specifically about advocacy and the potential for health communications research, the importance of advocacy, and whether it's in the global context, or we can certainly think about within the US as well, that there's a lot of good grassroots advocacy. The question is, can health communications research or strategies be used to galvanize advocacy, whether it's connecting with users and advocates, helping to amplify their voices? Anyone want to jump in on that question?
I think, so I'll just take a stab at it. I'll start us off and see if any of my colleagues want to jump on with me. But I think in terms of advocacy, it's important, obviously, to get the perspective of the people you are advocating for and to have them as a partner in the advocacy initiative. For me to think that I know or understand somebody's perspective other than my own is fallacy, right? So I need to be able to have a stakeholder, a group with me so we can understand what is needed. That's one part. The other part has to do with understanding what's in it for the advocates or the people you're advocating for. So why should they join you, or what is the thrust of the movement, and where is it going? To get to that, you need to be able to answer the question of what's in it for me. So we can't let it be a language only or words only type of a thing. We definitely need to get to the action. And by answering that question of what's in it for me, what am I exactly advocating for? Where's the evidence that this is going to work? How can I see that? Otherwise, I don't think it's going to be very beneficial. And I'll just stop there.
Great. Anyone else want to add to that?
I can chime in here. And I think one concept that my team has been trying to address and really struggling with has been this issue of authenticity. And by that, I mean the authentic voices of people who are being affected by a specific health issue. And I can give one example of a pilot study that's focusing on the risks and protective factors associated with smoking behaviors among adults who identify as transgender or gender expansive and who are thinking about quitting smoking. And through that small pilot study, this was funded by the NCI, by the way, through a U54 mechanism at Dana-Farber Cancer Institute and UMass Boston, we utilized what is known as a digital photo voice approach to ask participants to share pictures of situations when they were prompted to smoke or when they were protected or prevented from smoking, and also to include captions in their own voice, in their own words, what those situations and contexts were. And I think that has really yielded a very powerful set of stories, brief captions, as well as real world images of the lived experiences of the participants in terms of their struggles with smoking and avoiding smoking. And I think those types of strategies for data generation, but also capturing the authentic voices of people who are being affected by a health issue could go a long way in terms of being part of an advocacy strategy for promoting the interests of specific populations and to garner support for higher level policy or societal responses to those issues. So I'll pause there.
Great. Any other thoughts on this one?
Just to capture another side of that, I think that what we're struggling with at our cancer center, and I know that it's happening at other cancer centers as well, is how do we communicate, in terms of kind of engaging our communities in our science and having them support the work that we're doing, and then moving towards maybe how, from evidence to policy, how do we communicate that science to the public? And I think that's actually a really interesting challenge in terms of health communications. Like, what kind of tools are we giving, particularly like our basic scientists and clinical scientists, to be able to have them describe the work that they're doing and the potential impact of the work that they're doing in a very accessible way. And so we're thinking a lot about, and that can, I think it's important for our scientists as they talk to just lay people in the community. It's going to be important as they talk to legislators and policymakers. We think about it with philanthropy and donors as well. So I think that that's really an area where I guess I'm seeing I think there's a lot more activity, in part because of some of the mandates of the NCI around, again, how do all of our scientists at our cancer centers engage and interact with community members?
Great. And Matt, anything you want to add?
No, I think those were terrific responses. I'll hold off.
Okay, great. So yeah, with more and more questions, we'll probably try and just get a couple of responses per question, so we can get through more of them. The next question, I think, recognizes already how much wisdom each of you has contributed, and asks, so where, besides the fact that you're probably four very busy people, where can we find communication scientists to collaborate with? Any thoughts on that one?
Well, if you work at a university, you probably have a department, if not a school, related to communication, and so I would certainly have a conversation with colleagues there. I would also suggest that while it doesn't have communication in the name necessarily, if you've got a school or a department of design, and specifically information design, boy, I would talk to those people too. I would say, of all of my cross-disciplinary collaborations, I've probably learned more and apply it daily from things I've learned from colleagues in information design. So I would suggest that too.
So if I can just real quickly, and would be great to get other folks' advice on this. Matt, someone else asked, to that point, can you talk a little bit more about communication design and evaluation and what that refers to?
Well, so I don't purport to, the way I think of it may not be the way everybody else thinks of it, but I guess I would say that there are a lot of communication theories and experiments that help us to understand how people process information when it's presented in certain ways. What are the things that help them to, both understand it, connect to it, find it relevant and useful to them, and be able to act on it. And there are tactics that can improve the odds that all of those things happen. And so communication scientists know that. Information designers know that as well. And so, I don't know that I could do justice to all of the particulars, but I think engaging with people who do that work, or at least compiling, and we could probably do this, a set of key readings could help people to think about what approaches might be worth considering in certain situations for certain communication outcomes.
Great, thanks for that. Another question that pops up, and I think you talked a little bit about how communication science can influence implementation science. There's the converse of the question of what do you think communication scientists need to learn from implementation science? Any thoughts about that one?
David, the first thing that came to me, I can at least start, and then hopefully other panelists can add to it. One of the first things that came to my mind was that a lot of implementation science is focused on organizations and organizational behavior. And while that is, while that is a relevant audience for communication science, I don't know that it's as central a focus as some other things. And so the idea that implementation scientists think about and know about how organizations make decisions and what drives them, and sort of organizational behavior, and even things like, different organizations aren't all the same. So public agencies, for example, have a very different set of, of motivators and, deliverables that they're responsible for, and even organizational leadership. So how do decisions get made to try something or not to try something? I think all of those are things that communication scientists would benefit from, that implementation scientists think about pretty often.
Yeah, I would agree with that. And actually, I would just expand upon that just a little bit, Matt, because I think that you're right on with that comment. I think, though, the implementation scientists maybe just know it so well, they don't even realize what they're doing. So maybe making it more explicit so that communication scientists can then incorporate it into their own work. Sometimes what they do is more the way a meeting is structured, just as an example, how an organization structures its meetings. Your meetings can be more or less effective based on that. But within that structure of the meeting, there are definitely communication components that maybe the implementation scientists don't necessarily think about. So again, it's some of that would be helpful. Also thinking about the various forms of communication, whether it's verbal communication or flyers or email messages or banners or any of those things, they're all communication, right? And many organizations do a terrific job with getting the word out about some things without really thinking through exactly what was it about this message that was so powerful and led to such success.
Great. Any other thoughts on this, Haley or Andy?
Yes, I have a comment in terms of the thinking, having participated from TIDER and working with implementation science researchers on my team, is the emphasis on sustainment or maintenance or sustainability. Once an evidence-based practice has been handed over to an end user, I think that component is really critical in terms of the way our lab has been approaching our projects in terms of developing effective anti-smoking messaging for disadvantaged populations. What happens at the end of a 5-year grant, at the end of the funded period of a study? How do we ensure that all the hard work that has gone into to evaluate the effectiveness of a communication intervention ultimately gets sort of longevity in terms of its implementation in the real world? Those types of questions, I think, has really been important in our thinking of the design for maintenance or the design for sustainability types of efforts that we build in from the get-go in year 1 of our study.
Thanks. Haley, anything? Yeah, please.
Or just briefly add, I think that within implementation science, being able to just think systemically is really critical. And I think that that's really important, I think, for health communications work as well, especially as we think about, things like audience segmentation or kind of more targeted or tailored messages, right? And thinking about not only around, being conscious and aware of not only individual characteristics or even group characteristics as they might influence, health messaging or an intervention, but, thinking broadly in a more social ecological way and contextually.
Great. Thanks, everyone, for those comments. I'm seeing another question that talks about struggles that some have in framing messages for community cancer providers and encouraging them to adopt evidence-based practice. The question is, are there conceptual or theoretical models or frameworks that you all work with or can point to so that there can be more of a deliberate focus on appropriate framing of messages and what the appropriate outcomes are? Any thoughts about the conceptual basis for health communication science that might be relevant there?
David, can you reframe that question or restate it?
Conceptual or theoretical models or frameworks from health communication science that would be helpful for people who are thinking about implementation, and that there's probably a sort of communication element of that. So are there models that that people should draw upon so that they have a good sense of how best maybe to develop messages or how best to test them?
So I'll take a first stab at this, and again, maybe others can join in. I think this is an area where we probably could improve, where communication science, for example, might provide a crosswalk that would help people. I mean, from a very practical perspective, it would be useful to say, look, I have a certain sort of a problem that I'm trying to solve, and here are some of the key attributes of the challenge and the population. Are there particular insights from communication, whether those are theoretical or empirical or tactical, that that might help me here? I know that some of us, Haley mentioned this work before, some of us have worked in narrative communication, and there are some models that have tried to do that. They've tried to spell out what are some conditions, some circumstances where narrative communication might be especially valuable in supplementing other forms of communication. I don't know whether the same sort of playbook, if you will, has been developed for other tactics, whether those are framing. I think it also exists for tailoring and targeting, and what, when are the appropriate uses for that. But again, this might be the sort of thing that that could be compiled or developed when it's absent, to help make it easier for people to find and choose approaches to reach their goals.
So I'll also add a little bit here. I think part of our hesitancy on the panel, maybe I shouldn't speak for everyone, just myself, is that there are so many different types of communication, and there are therefore so many different types of communication theories. And so it really kind of depends on the kind of communication you're looking for. So for example, if you're looking to talk about communication through an electronic health record or use some kind of a technology, then you really want a theory that is based in the semiotic or cybernetic traditions of communication. If you're looking to really, jumpstart people into action, something from the rhetorical area of communication theory might be helpful. So there's really not one overall conceptual model to think of. It's really very much based on the kind of communication that you're interested in. Communication itself developed over 1,000 years ago as a discipline, and it arose, interestingly, in many different disciplines. So, mathematics has communication, physiology has communication, literature has communication, and because of all of these different entry points for looking at that concept of communication, then you've got all of these many divergent kinds of theories.
Thank you for that. Anything else to add, Andy or Haley?
I sort of approach this question with this lens of, is communication, capital C communication, the intervention that you're trying to get your providers to adopt, versus maybe smaller case communication as an intermediary implementation strategy for getting them to adopt some other form of evidence-based practice. And depending on those two different scenarios, you might be applying various theoretical models or frameworks to achieve those outcomes. So I'm with Melissa in terms of being selective in terms of specific theories or frameworks, depending on the outcomes that you're hoping to accomplish with your providers.
Great, thanks. Haley?
Hi, sorry, I keep having to mute myself because I want to minimize background noise. I don't have a whole lot to add to what's been mentioned.
Okay, well, so we are right about halfway through, and I am going to turn things over. This is our passing the baton to Robin Vanderpool, and a change in picture, so you can see yet another fire. So Robin is going to take over the facilitation, and so before I have to sign off, just want to thank so much our great speakers and the wonderful questions that I know that we'll have more of a chance to get through. So I'll be looking forward to watching the second half of this a little bit later on. So thanks, everybody.
Thank you, David. As we all get settled into the campfire at this new campsite that we're at and get ready for the Memorial Day weekend, we'll transition to some of the other questions that have been coming in. And one that I'll put out to the group is thinking about in implementation science. We often are thinking about taking evidence-based interventions and adapting them for the particular audience that we're working with, whether it's cultural adaptation or organizational or whatever frame where we're trying to do the scale up and move this out into a broader context, move that intervention out to a broader context. And so one of the questions is thinking about maintaining fidelity of that original intervention, and then the need to also adapt. And so thinking about communication in that space. Where does communication fit? And I'm going to go in two buckets here. Where or how does communication play out in thinking about maintaining fidelity to an intervention? But then also, how does communication fit in thinking about the adaptation of that, and maybe even lessons learned from thinking about tailoring in communication? So whomever would like to go first with that. And don't feel, you can answer either or of those buckets.
Robin, I'll take a stab at the adaptation part of the question, and I'm not even sure this will be a response as it is maybe an attempt to kind of raise our collective consciousness. As somebody who's interested in health equity issues, I do feel like much of what we call adaptation is more precisely modifying an intervention that worked with maybe a general population for use in an underserved population. And I would like to submit that while that's good and it's better than not doing it, what we really need more of is we need solutions, interventions that were developed from the outset in partnership with those vulnerable populations or underserved communities, rather than trying to shoehorn some other approach, to make it appropriate, for different groups. And I think we're starting to see more of that. And I do know that a lot of funding agencies, NIH included, are strongly in favor of that. But I just want to say that out loud as sort of a challenge to all of us who are working in this space, because I do think that's the way we should be approaching it.
Yeah, I agree with Matt, and I'll just take the other bucket, fidelity. Fidelity according to whom? According to the researchers who developed the intervention, or according to the stakeholders who are expected to be the consumers of the intervention. So I have a little bit of a problem with fidelity, the way it has been thought of up till now. And I would really, again, challenge us to think a little bit differently about fidelity so that it can actually be what is needed by those for whom the intervention was developed.
And chiming in here about the discussion around fidelity, I think it is really important to identify what is the secret sauce, right, of the intervention, without which the intervention will no longer have the same or intended consequences on the outcome that we're after. And figuring that out is part of identifying it a priori and testing it carefully in the form of experiments or randomized controlled trials and so on, but also discussing with the end users and the targeted populations of those interventions, what seems to be the core component of an intervention that is making the difference in their deciding to adopt a health behavior or to change their health behaviors or to seek a specific health service.
Yeah, maybe I can just, even share a very recent example of, how we're working with that, because I think that's a really, and I'm trying, I appreciate everything that's been mentioned around, how are we defining fidelity and how are we thinking about adaptation? With one of our stakeholders groups is an LGBTQ council that is thinking through, that works with our investigators in our cancer center on, a range of issues. And there's been this interest in this group about around cancer caregiving and really supporting LGBTQ cancer caregivers and supporting them in some unique challenges that caregivers face. So, we work with this group to identify to look at interventions that might be appropriate, because the initial idea was to identify an intervention that could be adapted for this particular population. So the group worked with some of our researchers to kind of identify these interventions and to narrow it down to those that they thought they would want to actually work on long-term for adaptation. And, that is certainly the struggle. It's like, well, they identified an intervention that seem to be most appropriate for the group, but even within that, there's still some, modifications that they want to make. It's not it certainly is not, even though there are elements that they feel that are that resonate with the group in terms of how it might support caregivers. It doesn't necessarily capture everything that they think is important for this area. So, we were actually now working with the developer of the intervention to kind of think about, okay, what are those core elements? What are the things that are most important, to say that, to kind of, that speaks to, that issue of fidelity, speaks to, okay, what, how, to help us understand how true are we staying to. At what point does it become something new? At what point does it become something different, given some of the changes that we're proposing? But I think that along with that, once we identify what those core elements are, I'm really excited about working with both the developer and our group in terms of thinking about how do we change maybe or adapt some of those messages, right? And change some of the language, change some of the ways that we're presenting that intervention so that it really can be most effective with our end users.
Robin, can I chime in here on fidelity real quick?
Of course.
So, we care about fidelity because the assumption is that, fidelity is linked inextricably to effectiveness, through research. And so what I would encourage people to think about is, imagine sort of a 2x2 where the intersecting axes are effectiveness, but the other axis is demand. Like, how much demand is there for a particular solution, for a particular intervention? And I think as scientists, we tend to place more weight on fidelity or effectiveness than we do on demand. And I would encourage people to think about how much fidelity or effectiveness might you trade to get more demand. And I think from a population impact standpoint, I feel like I could argue, and we've written about this a little bit, I feel like I could argue that if you had higher demand and a little bit less effectiveness, you may actually get more impact. So I don't want us to be so wed to fidelity that it gets in the way of developing solutions that people and organizations actually want to use.
Thank you, Matt, and Haley and Andy and Melissa for those comments. I'm going to switch gears just a little bit here. A couple questions have come in related to technology. So as we know, many of our interventions that we're implementing, our evidence-based programs and strategies rely on, for example, in a healthcare system, the electronic health record, or now certainly post-pandemic telehealth services. Also thinking about patient portals and where interventions may have a mobile or some other digital component to them. how can we engage our communication scholars and again our communication research and strategies to make that technology aspect of our evidence-based interventions and again practices more effective?
So I'll start us off here because this was actually a primary focus of one of my earlier studies. And there's a concept of media richness that says that the most rich medium is the face-to-face, where you can actually see somebody and you can see their eyes and see their expressions and their body language. And as you move through different kinds of technology like the telephone, it's still a relatively rich medium. But as you go down the line, eventually getting to paper and pencil, it's the least rich medium for communicating messages. And what we find with technology in healthcare is we are not teaching or educating our clinicians on this one fact, that you really need to consider what message do you want to convey, and is the medium you're thinking of using the best medium to convey that message? And I'll give a really powerful example from a few years back. In Dallas, Texas, where that first Ebola patient came to the hospital, Parkland Hospital, I believe. And the nurse asked him about his travel, and he had a high fever and all of that good stuff. And she noted that in the electronic medical record. She noted, she documented it. That information was in the electronic medical record, that he'd been traveling in Africa, that he had a high fever. But at no point did she tell the physician. So this obviously was an important piece of information that needed to be conveyed face to face. But because it wasn't, that then started a whole cascade of events here in this country. I'm sure there are many other examples like that, but this idea of technology, of having that medium match the message, I think is really key.
Yes. Well, thank you, Melissa, for that. We'll go on to some other questions that are coming in. One of them, so I'll paraphrase here, but often, for example, in our studies in our measure and related to measurement, we may check kind of a yes or no, was the message delivered? And then, was some outcome documented, yes or no? And so how can we move beyond that to get to, again, richness of the data, of the depth of the interaction? What other communication measures, processes should we be looking at? What should we be capturing in a provider to provider interaction, or a community and academic partnership? But I guess I'm thinking very broadly, but those more than just the yes and no, like did it occur? But what else can we be measuring around communication to see if it's really affecting the success of these interventions? Any thoughts?
Well, I think that, in terms of, I think there's something to be said for not only as part of that, how are we collecting that information, right? So are we collecting it just simply on, pen and paper, or, just subjective, getting that subjective evaluation of that, that interaction, or are we, capturing other ways through audio, through video? So I think that, just something to mention that as an important strategy to kind of, or a different way of kind of evaluating the impact of those communications. And then even from there, not only having just researchers or academics look at those interactions, but having, people from different stakeholder groups kind of participate in that, that observation and that evaluation as well.
In our, oh, go ahead.
No, go ahead, Andy, go ahead.
Oh, yeah. So I was just going to chime in that in terms of our work in creating effective anti-smoking messaging, we utilize this measure of perceived message effectiveness a lot in trying to understand a priori before we invest a whole lot of resources into creating a professional, finalized version of a health message. We want to understand audiences' perceptions of how believable, how convincing, how novel and important the message is. And I believe Xiao Chuan Chao is one of the attendees today, and this is a measure that was validated by him and his team several years back and has been utilized widely by the Food and Drug Administration in its current slate of health campaigns, focusing on anti-tobacco messaging for various audiences. So that's one set of messages that I see potentially having the potential of being implemented for measuring message effectiveness across other contexts.
Melissa?
Yeah, I was just going to build off what Haley was saying. And I think in terms of measurement, we can maybe take a step back and think about communication more broadly as including not only the verbal components, but nonverbal components. So nonverbal communication is very, very powerful, and trying to measure that or capture that, as Haley mentioned, through audio. Well, you're not going to capture nonverbal through audio, but video. Video is a great medium for capturing both verbal and nonverbal communication. And trying to find ways to measure that, I think, is a frontier that maybe it's time for us to get to and confront.
So I did see, this is Matt, I did see Cynthia Bauer's comment earlier about, this is pretty basic communication science stuff, and I don't disagree with that. But I'm gonna pile on more basic communication stuff in answer to this question. So if you go back 50 years or so, there's kind of an established list of outcomes, even hierarchically arranged, to think about how communication influences at least individuals. So beyond just, hey, did we deliver this? It's, does somebody remember receiving it? Did they pay attention to it? Do they understand it? How do they process it and integrate it within, their own life experience? Do they act upon it? And those aren't just survey items. There are also a whole bunch of methods that get at, sort of, like cognitive processing, things like having people do thought listing, having people do paraphrase tasks. And so if, from a research standpoint, if you're trying to figure out, what exactly are people doing with this information, whether it's from an interaction with a provider or some other exposure that they have, there are lots of good ways to do that. So hopefully that adds to the responses.
Yeah, just to also piggyback on that a little bit, especially as we think about them, genomic medicine and some genetics research, did they share it with other people? How did that message get communicated to other parts of their social networks and family members and so on?
And in the space of patient-centered communication, Lauren McCormack's work at the RTI has been really instrumental in operationalizing measures of various functions of patient-centered communication and whether that has been achieved beyond a checklist of yes or no, but measuring the quality of the patient-provider communication across information exchange, decision-making, managing emotions, fostering healing relationships, and other domains. So those may be another set of literature that may be helpful for those who are conducting research in the healthcare communication setting.
Okay, so we're going to close out. I've got about 2 questions that I want to bring us potentially to the end of our time together. The first one is a really nice question, thinking about cancer care delivery and how complex it is, and whether that's in, again, a healthcare or community setting, and thinking about cancer across the continuum of care. It's often done in a team-based environment. And the team can be made up of lots of different professionals, lay individuals, community members, the patients and families themselves. But how can we think about, again, with our interventions and implementation, thinking about how better to improve communication across those teams? And if there's a particular example that you'd like to give, again, whether it's community or clinical setting, or open to, specific examples, but how, what elements of messages are essential when thinking about the team-based communication approach? Did we suck you off?
I feel like I'm not so qualified to answer this, Robin. Most of our work is in community settings. I'll defer.
Yeah, so I can maybe take a stab, but I definitely need help from the others to round it out. Thinking about team-based communication is tricky only because every member of a team should have a separate but complementary role for the patient, whether that's somebody who's being diagnosed, treated, a survivor, when we think about cancer care continuum. And unfortunately, in many cases, we found, for example, in a study that we did in ambulatory oncology, that there's far more overlap in roles than complementarity of roles. And then that makes it difficult for that team to function effectively and deliver a message to the patient. That's one thing. Another thing is that when the physician delivers a message to a patient as a member of the team, that then should include at least one or two other team members at the same time who are there present with the physician to deliver that message to the patient, so that the patient is hearing a similar story from all members of the team. Unfortunately, what happens, I'm thinking specifically in acute care, is that the physician goes in to deliver a message, but no other members of the team are present. Somebody else comes in then to deliver supposedly the same message to the patient, but it's not quite the same message, and it causes confusion. So those are two different ways of thinking about team communication that I think might be worth maybe unpacking a little bit so that we get to better outcomes for our patients.
Thank you.
I think
Okay.
as
Go ahead, Haley.
I was going to say, the way I think about it in some of our work, particularly as we try to bring together, folks from different sectors, is how, is kind of thinking kind of almost like capacity, building capacity in terms of, language, in terms of jargon. And so I would just share that as, another starting point, even before, as we try to kind of work together, try to move towards something collaborative. And for our work, it's been really important to kind of take some steps back and kind of talk about, make sure that we are kind of sharing definitions, sharing meanings, and so before we can even really move forward. So that, in some sense, we're sharing the same, sharing that same language.
Yeah, that's really important, Haley, this idea of our jargon. In healthcare, we as healthcare providers share a common language, right? But the patient doesn't necessarily know that language. They may think they do or they may want to, but they don't. And so we need to be very sensitive to the words that we use and make sure that it's not jargon, so that we use language that the patient can understand. So that's really important. Thank you for bringing up that issue of jargon.
Okay, so we've had, again, a couple questions and one that we had been thinking about as a team as we prepared for this webinar is how to, one, continue this conversation, right, around the intersection of health communication and implementation science. How do we as colleagues in the field promote more capacity building and more connections in this space? There was a question earlier about how do the implementation scientists find health communication scholars? And I think then the reverse could be asked, how can health communication folks find implementation scientists and colleagues? So maybe I'll pose that as one question, but just with a follow-on of how do we continue to grow this cross-talking with one another and integration with other stakeholders?
I can chime in here, and I welcome the other panelists to weigh in as well. So there are past models that I alluded to previously in the beginning of this webinar, the NCI-funded seekers and the cancer research networks. Those were some examples of really structural supports for interdisciplinary cross-pollination between health services researchers, implementation scientists, communications researchers, and those types of long-term structural and funding supports for trainees, researchers to work across these different disciplines are, potential ways that can lead to these, cross that we're hoping to achieve. The current funded sites of the Implementation Science Centers in Cancer Control, the ICS3 sites, to my knowledge, only 3 out of the 7 funded ICS3s have listed communication as one of the keywords within their projects. PEN is one of them, but I see that as another potential longer term structural support for promoting these collaborations intentionally and explicitly to include mechanisms, incentives for pilot projects between health communication scientists and implementation scientists and their trainees. So I'm just going to put it out there as a potential way to foster that.
Robin, I'll just pick up on Andy's comments about training, and there are in the implementation science world right now actually a lot of training opportunities, both special programs as well as through clinical translational services that a lot of research universities have. So it may be possible, in order to introduce communication science to people learning about implementation science, to maybe develop some kind of core information or resources that could be used by those training sites. Now, going the other way though is maybe an interesting and less obvious solution. So how can we get more communication scientists who aren't doing or aware of or want to know more about implementation science? How can we get them connected to some of those implementation science training opportunities? And that seems to be a discussion worth having. And maybe folks who are in the communication science world who are attending could share ideas about how that could happen.
Okay, so let's do a round robin, if we could, with one final comment or takeaway that you would like to leave the audience with this afternoon. Again, from your own personal experience and research in this space, or something that was brought again to light during our conversation today. But one just parting thought before we turn it back over to Sarah to close us out. And I'll start in the order that we started the very first with, and Haley, if you don't mind to go first.
Well, I guess maybe my parting thoughts would kind of follow from some of the comments just now, that there seems to me to be very natural kind of fit between health communication science and implementation science. In terms of how do we, one of the ways that I think about it is that how do we even going to share and talk about innovations that we want to move into clinical settings or community settings. One method actually that I kind of wanted to mention today that I think really is promising in this area is, and it may have been talked about in previous webinars, but bootcamp translation, where you're literally kind of bringing a body of evidence, or you're bringing work to your community stakeholders, and then from there, and again, what do you need to actually move into real world practice, and then working with stakeholders. It's a process for working with stakeholders around how do you then communicate, and what kind of messages what is important for people in that real world setting to know about that innovation, and then how do you talk to people about that innovation? What messaging do you create? And it's kind of then a collaborative effort to kind of to create that messaging. So I think like approaches like that are really important. How do we even talk about the interventions, or again the discoveries that we want to move into real world settings? And I just would call for more, I would like to see more methodology, or kind of more evidence around the strategies we use to kind of make that happen.
Thank you, Haley. Melissa?
So for my parting thought, I want to focus on the real world, like Haley just mentioned. Real world practice, what people really do, what our clinicians, our patients actually do. That is, to me, the heart of implementation science. That's where the foundation is. But when I think about implementation science, I think of it as more conceptual or more, I don't know, higher level than actually what happens on the ground. And I think communication can serve as that bridge between the actual science of it, the theory of it, and the actual practice. And that's what I would like to encourage people to do. Clinical practice is messy, it is complex, it is ambiguous, it is unknowable, but that's what it is. And we just need to find ways to engage with that and then to work with that instead of trying to put some kind of artificial structure or boundary around it and say, oh, well, this is what it should be. No, it is what it is. And so how can we work with that to improve care for our patients?
Thank you, Melissa. And Andy?
My parting thought would be, in terms of implementation science and health communication researchers and practitioners, we're all after the same goals. We are all after this outcome of getting evidence-based, life-saving practices and programs into routine care and routine practice at various contexts to improve population health outcomes across prevention, screening, treatment, survivorship, and also to eliminate disparities in those outcomes among priority populations. And the way we do this through our research, through frameworks and implementation science and communication can get us there. And I want to also weigh in on the discussion around capacity and training and cross-training across these two different fields of practice and research for early career health communication investigators. Seek out those training opportunities either within your institution, in implementation science, or one of the mentored training programs I mentioned earlier, the MTDIRC, the TIDIRC, the TIDER programs. Those are one of the important ways that health communication scholars can get involved in implementation science.
Thank you, Andy. And Matt?
I was thinking about sort of disciplinary humility. And what strikes me as one thing that these two fields, implementation science and communication science, health communication have in common, is that often people think they know how to do it because it's easy or it's intuitive. Oh, well, communication, I communicate that. You just tell people stuff. Or implementation science, well, I've got this evidence-based thing. If I dangle it out there, people will run and want to use it. And of course, neither of those things are true. They're much more complex than that. And maybe just sort of acknowledging that and trying to partner and learn about the other discipline, I think will make us all more effective in what we're trying to accomplish.
Well, thank you all. On behalf of David and myself, I do want to thank our panelists for accepting our invitation to speak on the webinar this afternoon and for offering their insights and experiences and thoughts. And I believe that there'll be much more to come from this conversation. That certainly you've given us a lot of food for thought as two fields that can continue working together and learning from one another and thinking about different training opportunities, different other topics that we could even bring to the table, as Haley suggested earlier, around implementation science and community outreach and engagement, or even health communication and community outreach and engagement. There's so many intersections between all of the areas that we work in. And I just, again, want to thank you all for being part of this webinar series this afternoon. Thank you to everyone who attended and submitted questions as well. And I will now turn it over to Sarah to close us out, but I wish everyone a safe and happy Memorial Day weekend.
Thanks so much, Robin. I would only echo those thanks and again, thank the audience for such a great spate of questions. We have a lot to work through and so much to think about in using these great questions to develop content for future sessions. So with that, I will let you all know that an archive of today's session will be made available shortly on our website. Thank you again for joining us. We hope to see you at our next session in June. You may disconnect at this time. Be well, everyone. Thank you.